Excellent recording process. We say okay. Welcome back to our session on folate receptor alpha in Tubo-Ovarian Carcinoma. I'm here with Adelina to discuss some of these cases with you, and I'll give you the results of the circulation. I think we had a lot of people in the circulation, so it was very, very well received, which is great. As usual, you're very welcome to unmute yourself and make some comments. You're absolutely welcome. But if you don't want to unmute yourself and make comments, you can write in the chat, and Anna and Sarah will monitor and will be aware of the questions or the comments that you're making. So we are very grateful to AbbVie for sponsoring this event, and really happy to bring you these things with no extra cost to you participants. So the first case, just a little kind of housekeeping rule. So we had asked you to score these cases into bins. I think as a pathologist, I find being useful, and I will talk a little bit about this bin, because the bins of clearly negative is something that I have very little reservation on whether I'm right or wrong. And so usually if such a case occur, I'm kind of happy to sign it myself. And those clearly positive is kind of also the same. But you see these borderline categories here, and this is where probably I'm going to ask my colleagues, I got this case, I'm thinking about something, but what do you think? Am I in correct shape or form, etc., etc. So it's also just for yourself, because, although a case could be correct in the diagnosis, for some positive, if I think I'm kind of thinking it may even be negative, and everybody else says, well, this is clearly positive, I need to reflect and think about it. So this is for everybody. And then, of course, there is always the case, because we are pathologists, sometimes we cannot give an answer, it's not available. Okay, so the first case, kind of looking at this data, it looks as if it's a straightforward case, because most people thought this was clearly positive, 82%, with some people said it was positive, but it's kind of a bit close to the border of positivity. There's just a few people said negative. And this is our panel diagnosis. So, don't put a huge amount of weight on what we say, because, in reality, this is a very new biomarker. And, there are very few people with the right amount of experience to be able to say, well, listen to me, because I know the answer. However, it's kind of interesting, because we have 4 people that have scored this for us, and then 3 thought this was clearly positive, like the majority of those people. But one of these so-called experts, said, yes, but it's a little bit borderline. So it still is reflective of these things. Okay, shall we look at the case?
Sure, that's 15. Case 1.
Case 1. Very good. Okay, so I think the carcinoma was quite easy to find.
Yeah.
There's a lot of calcification, and then I think the preservation is okay,
Yeah.
Because I think you will see that some of these
typical,
some of these cases, you really need to negotiate and understand whether something is scorable, because they may be a little bit poorly preserved or maybe slightly necrotic. But I think all of the tumor is probably in good shape on H&E.
Yeah.
Not so some of my bodies. Yeah. Okay, so lots of tumor here, and this is, of course, remember our control, and we spoke about it, about this border of staining in the fallopian tube, but that sometimes has got no staining, and some other times, and now I cannot find an area, it shows a little bit, here it is, some lateral positivity, membrane positivity.
And we need that.
And we need that. Okay. So, and we also discussed last time we were together the fact that although, and here you see this little kind of, this is a necrosis. Yeah. Also discuss about that if the tube is not very well fixed and preserved and processed, they may not show this. And then in any case, about a percentage of the fallopian tubes, regardless of all your efforts, would not stain very well. So, you know, okay. So that's our, and also nice, this antibody is clean, doesn't have background, you know, okay. So this is our tissue. There's a lot of staining.
Yeah, seems like it's covering pretty much all the areas of tumors that we've seen.
Remember that we are after a membrane staining that we can see at low power-ish. So something like this is clearly there's membrane stain, but there are some cells that don't stay, or some areas that don't stain, at least at this power. We could go a little bit higher. That's the next power up. But yeah, there are still some tumor elements, tumor cells without staining. Okay.
It looks like them, at least there. Maybe we look at other area closer up.
Well, I'm kind of drawn to this absence of staining. Yeah. Yeah, which is real, you know. So I can see the difficulty. Is it borderline or is it?
We have for now only this area where we still have staining, but it's how much would you say in this area?
In this area here,
or the larger one? No.
Okay, so that's interesting because yes, of course, there are lots of cells with very little staining, but actually there is an area of these 2 cells or 3 cells that are staining with the correct staining intensity. So maybe the negative areas are not as negative
still
as
20-30%, and then we need to.
And then, of course, the other ones are rich. You know, these are a full house.
Almost 100%.
Yeah, 100%. Okay.
So this is nice because you have this apical staining. We've seen there are many papillae, micropapillae. And once you have all this on the outside, you don't even need to worry about the intensity here in these cells.
Yeah.
But that's only in tumor. As we talked earlier, the control needs to have lateral
membrane staining. So an area of the tumor like this is kind of giving you a lot more than 85%, yeah?
This is over 95% probably.
And then there are these little things, but they're okay. They're not going to be numerically very contributory. Some of these are immune cells.
I just wonder also if they're
necrotic or poorly preserved. Yes. Okay, and here I think again what is missing are probably macrophages and other things. Okay, well, I think overall positive.
Yeah.
I can see that if you first land here, you say this is borderline positive because you have a lot of cells that don't stain, but then actually probably all the others will increase this 75% to a bit more than
it's
that.
It's possible that this whole area is just 75%, but if we look at all the others are 100%.
Anna, you will tell us if there are comments, and please do unmute yourself and speak, but we could go to the next case.
I think so.
The next case, which will be here, number 2. So number 2, well, that was a little bit more controversial, wasn't it? Borderline positive, 50% borderline positive, essentially 50% negative, some of them clearly negative, 70 borderline negative.
And even almost 10% clearly positive. So at the time when I was scoring the cases, I thought this would be one of the controversial cases amongst ourselves, but it seems like we all thought the same.
Yeah, so among ourselves is 4 out of 4. We decided it was just below the threshold borderline negative. No idea. I can remember these cases.
So it's 18.
This one. Lots of tissue to see. What have we got here? Oh, these are all tumor nests in omentum. I don't know where we are in.
Yeah, looks like.
Yeah. Okay, so this
I can see how difficult this in view of the immune infiltrate as well. So probably that's, although the size of the tumor cells is
should
help
make
with that.
should help, but there's quite a lot of tumor. It's almost everywhere. I think there are areas with much less.
Yeah, a bit infiltrative there.
And here also, so there is tumor everywhere, but in different amounts. I find my overwhelming difficulties is understanding denominator in all these things, because
to quantify, especially when it's so spread out. And
look, yes.
And sometimes we just look at them side by side, right?
Okay, let's task. Okay, so again, our follow-up and tube, which we spoke about, and then here. Okay, so at low power, I'm kind of a little bit disappointed. To me, at low power, I would say I'm going towards clearly negative. But then I reflect that there is strong staining. If it's membrane staining, we'll just have a look. Oh, this is, yeah. So there is membrane staining in a lot of this class, and these darker areas actually is the lymphocytic infiltrate, is not tumor. So
yeah,
but this area is going to be poorly performing.
Yeah, I still feel like I need a higher power to kind of see where are my negative cells, if there are any, because
so here you have a few strongly positive membrane cells with membrane staining. You have this apical border that makes a lot of cells positive, but then there are cells that
piles there, cells
nothing with nothing. So this one, this area is negative, so it's below 70%, not hugely. This is not 10% or 15%, is maybe 50 or 40, 50%.
I would have
Yes,
thought.
40, 50%. Okay, and then you go to other areas like this. Again, it's kind of, we're probably not touching 75, but we are getting closer to 75%.
Yeah, this is pretty good still, but I think there must be.
Because you see, in reality, even these cells that look negative, but these borders may push you towards say, well, maybe I'll call these
This is why I'm a bit worried about this, because these are so three-dimensional, especially with this micropapillary architecture, where you have the apical portion going all the way around, and then you see a big clump of cells and you think this is negative, but you actually don't see their apical portion.
Yeah, do you know when I was showing you this thing, and I forgot where they are, these things here where I said, well, I think this cell and this cell could be positive because of these big apical things, etc. But maybe we are wrong at attributing membrane staining to both adjacent cells, at the cells at across. So maybe it belongs only to one. Anna has a question.
This case needs more explanation regarding the percentage of the expression, because many pathologists make mistakes.
Okay. Yeah. So I think to follow up on that one, if it's apical staining, that would be, if you have a microlumen, that would belong to a single cell. And then, but that's very difficult to tell in practice, isn't it? For each.
Couldn't that line of staining be considered line 2+ positivity?
The
line you show.
The line that we saw. Yes, the apical stain, usually, I think so, because usually kind of using your magnification rule, I need to hit this button here. At 10, you kind of see the apical staining. So probably it is probably moderate staining intensity, using the magnification rule in a way.
And even strong, I think.
Maybe slightly stronger, yes. We can see sometimes you can see at time 5, yes. So tricky case.
I think
so what about
the
people that said this is positive, borderline but positive? I was wondering. I'm sure I told you these things many times, because because everybody repeat himself or herself. And I told you what Bharat Jasani told me or taught me was make up your mind and then check your results by going through the tumor. So let's say I decided I want to call this thing positive, and then do a quick reappraisal. Look at an area and say, is this positive? And you look at it and I think myself, no, not really. I think this is not positive. Okay, then go in a little bit in a random fashion. Look at another area. Is this positive? Oh yeah, these are the microlumina, aren't they? These little things. But actually there is a lot of cells where I cannot really. So maybe I'm wrong. This is not positive. And you could do this in many areas. And then you yourself feel, actually, I'm losing my confidence that this diagnosis of positivity is correct, because it doesn't really reflect what I see.
And
this
if
checking,
and
this
if it's
checking.
borderline, then you would also have someone else looking at it.
Another, yeah.
How can you visually discriminate between 65% negative and 76% positive? Most of the participants scored as a case as a borderline positive.
Yes.
Next one. Maybe we should start scoring staining using thicker section and a confocal microscope.
Okay, so let's take this thing. Very good comment. So thank you for doing this. So how do we know it's 75? We don't know it's 75 unless you are so patient and count.
Unless we count them, but even like that, because it's a matter of interpretation as well.
Yeah, there is also an element of interpretation. So clearly, something like this would benefit immensely from an image analysis tool that would do all the counting, because this is a complex section. You know, it's not a lump of tumor and we kind of negotiate the issues. So yes, so I mean, I can see from cases like this that what we need to provide is an atlas. Like you remember when we done for the PD-L1, this is what 10% means, this is what 50% means, etc., etc. So then with Mario's example, because somebody patiently, you know, possibly Emilia, I don't know, would have counted all the cells, and then we know that that is 65% or whatever it is. And then what I would do is I would put the slide under the microscope, look at my atlas and say, what does it look like? And then I find my number. So maybe a reference atlas here would be capable, helpful. Confocal microscopy, yes, of course, we can use all kind of tools and trying to understand it. But the reality is that this is an assay that has to be delivered on thin sections using light microscopy. That is the biomarker. This is the assay, and so we kind of need to get our head around it. So don't be too discouraged, because when I scored this circulation, I thought that whoever was in charge picked up all those bad cases, all the difficult cases. Yeah. Anyway, but do you see what Adelina is doing now? She's going around, and as we go around, we don't really see positivity. We don't really see 75%.
And besides these clusters that you pick up a low power, there are clusters that are completely, or tumor cells, like look at this area, which you will never see if you go at a low power.
So some tricks which may or may not work, but one trick that, okay, I like immunohistochemistry. So what I would do is I would use an immunohistochemical stain that tells me how many tumor cells there are, maybe a pancytokeratin or something like this, so that it gives me a reference. And then I compare this one with all the staining I see on FOLR1, and I say, I mean, are they all accounted for, or am I missing a lot of cells here? Because what Adelina was showing you, this negative area, these are tricky to see, aren't they?
And there are many more. And I think what Corrado is saying is a very useful visual tool, and especially in inflamed tumors like this one, is incredible how much difference between what you thought the number of tumor cell.
Yeah. And what is really on the section. Okay, so I kind of I'm really grateful that you're all here and you're making comments. Understand that we are learning with you. You know, we are not here to give you the wisdom of whatever, because that's you know, our clinical experience is limited. Okay, was there something else? No. Case three, as you can see, this is a sticky one. Look at the panel. 2 thought was borderline negative, 2 thought was borderline positive. So, yeah, and then it's, I told you, these are not easy cases. I don't know who chose them.
After this one, was the most challenging. So.
Okay, but in a way, I think, okay, it's a little bit demoralizing, because when I have a circulation and I get 3 cases wrong out of 6, I feel kind of monkeys would do just as well. But I think it's also useful to discuss difficulties, you know, don't be too demoralized. Was it 20? This one?
Yeah, 20.
Okay, could like a lymph node. There's a lot of tumor.
We were looking at the areas of tumor, and
there's a lot of necrosis here.
Very high grade.
But also the state of preservation of this tumor. This is a lot of coagulative necrosis here, which, by the way, and this is what always scares me about these type of changes, that you think, oh, but these cells are okay. But actually, they're not okay. They're really close to be necrotic. So I'm really curious to see the immunohistochemistry, to see how many more cells I have to exclude from counting, not just
say that there are immune cells interspersed everywhere is also.
Yes, absolutely. Like lymphocyte, tumor cell. Yeah, they're all intermingled. Plus, there are all these things that God knows what they are. Okay. So kind of all right, and then for good measure, also the section has got a hell of a lot of tumor. This is, not sure.
That looks artifacted,
crushed.
Maybe even photographed.
So in many ways, that's actually a kind of an important point that probably we should make. In many ways, you should look at the H&E and consider whether you are willing to, or before even you start looking at it, you say, I'm going to take this area and I'm going not to even look at it. I'm going to take it out of my assessment, because I think this has got too much artifact and it will be biasing my.
And we see that. Assessment. We see a lot in bladder biopsies when we have a lot of cautery artifact that PD-L1 doesn't stain or shows very funny staining that we shouldn't.
And then also, you know, the other comment, because this is a really inflamed tumor, isn't it?
I wonder if this is node metastasis.
It could be metastasis, but look how closely in close contact they are, and also look at the vacuolations in the cytoplasm. So that means that these lymphocytes are probably eating them, which means that, you know, maybe there are also some cells that are damaged by these activities, and the staining may be difficult to interpret. I think this is the one where I struggle with staining. Okay. Okay, good. We are kind of low power, could be positive.
Lot of color, but we're at 1 magnification 2 times.
Okay. Let's see. So these were the areas, you remember that I first pick up on the necrotic, yeah? And you see, look, these are the cells that we thought they were kind of better preserved, but look at this. This is the same kind of rubbish, non-specific staining that you see here. This is kind of.
It is interesting because you need to understand the trend of the tumor as well. Because sometimes in the areas of necrosis, you see less staining. Sometimes you see more, like with PD-L1, for instance. You see less with HER2. I've seen HER2 positive cases that had the areas of necrosis, and the cells just around the necrosis were completely negative. So better ignore them. What do you think?
Well, I think, you know, for instance, when I looked at the H&E, I thought, oh, maybe these cells are scorable. Now that I look at this staining, although I can see that there are possible membrane staining here, you could accept these things. But actually, to be honest with you, I think it would be much safer to take this area and take it out. This is too. The process here is not very safe. I'm not going to score it. Okay, so there are all these other areas. I'm uncertain again of the status of preservation. So you see now I kind of picked upon the fact that dying dead cells have this granular cytoplasmic staining. And now even in areas that potentially could be better preserved, you have this pattern which,
this is not even, it's more like granular cytoplasm. It looks like it stains bits of cells, cytoplasm.
Yeah, so again, I think it tells me preservation is not brilliant. There are islands where you can say, well, why don't we score these ones? Okay, so it's a judgment call. Whether you feel overall in this island, I'm not really very happy, I'll take it out. And again, it's a personal decision, or whether you feel I'll pick up these bits I score, these bits I called it non-specific and I don't score it. I don't know.
But again,
there are areas that are very positive.
Where the tumor is preserved, then it's much more.
Yeah. Okay, so I think this is an example of what possibly the tumor is. The tumor is expressing, even to notable quantity, and then there are cells that are not expressing. I mean, I think I'm at too high a magnification. I think these are probably weak staining intensity.
Yes.
These bits here.
Yes, I think you're right.
So, and the percentage of these would be maybe 10-15%.
Of negative cells.
Negative cells.
I should think so, yeah.
Okay. And here, these cannot be tumor cells, are they?
It is possible. They look like they're forming clusters and
maybe these are tumor cells again. Yeah, they're tumor cells.
Maybe they're just.
Okay. And again,
maybe it's a little bit more here, and
this is more a higher percentage of tumors. Okay, so I'm kind of formulating a view. Again, we are hitting areas we don't want to score. I think that's an immune infiltrate.
Yeah, but given that even over where the areas of immune cells are, because of the necrosis, the staining also is so much dirtier than this is again an area of necrosis, and then
the tumor is better representative, and again in places that are negative cells.
But they look like about 20%. I mean, every field you kind of, maybe here is more.
You have a little rim of cells that don't really, that you cannot call positive.
Yeah,
because
this is
weak staining. Yeah. And again, so I think what I'm getting the impression is that the tumor has heterogeneous staining, and the proportion of cells that don't stain, they don't vary a lot. I mean, there is, I think it's a borderline case, for me, it's a borderline case.
Yeah, here is.
But so, I start to find too many cells that don't stain. Although, actually, when you look at this, I mean, they look negative, but actually, they all have a border with something staining. So maybe they're all positive.
Now, because we're talking about ovarian carcinoma, you sometimes get this pattern of very tight micropapillae. And that could be one of those kind of structures. And then you get staining on the outside. Here you have space around it, and you can better see it.
Yeah.
But
okay. So thank you for this case, Adelina. So how do you think, what are your thought process when you scored it?
I think because I might have excluded a lot of those areas that have necrosis, and I didn't think they were well preserved. I call it borderline positive. Now, it is very challenging also because sometimes you see dots. I mean, I think our participants would like us to try and give percentages. And I mean, for instance, for this area, which is probably most of the tumor looks, or half of the tumor looks like this, and then we have more positive areas.
Okay, so in an area like this, what number would you give?
So I think what stains, what magnification are we?
Maybe 5, try 10. This is 10.
No, this is 10.
Okay.
So then we have quite a bit of weak stain. Maybe it's about, how much should I give it? The thing is, you see, you have these dots that should count as well. So maybe it's up to 20%.
20%. So you think it's more than 75%. Okay. So let's see if you're right. So if if 20%, so 20% is what? 1 cell in 5. Yeah?
Yeah.
Okay, so I should be able to find a good number of negative cells. Okay, help me doing this. So help me doing it.
There are areas.
These are negative cells.
Yeah, and the cluster next to it, to the left, I think.
These are negative cells. These are negative. I'm not sure that these are negative cells. So maybe one is negative. These ones are negative cells. Yeah.
But even
where my arrow goes, although 1 or 2 are included in the positive one. Okay, so there is a little strip there, and then maybe a little island here, but not very many actually.
Some there where you were with
there. So even here, that's you feel there is lack of staining, but actually, which one of these cells is negative? This one maybe?
Well, there are a few exactly where you are, and
Just
if you
one
go up
and
a bit, because they're
yeah, so
smaller
and maybe this one, but no, because there is linear staining here. So actually, I am struggling more. I'll put it in the center. I'm struggling more than I thought I would to find negative cells. So maybe your thought about 80% it's correct.
And
yes.
there is that. I mean, probably this is a more average area of the tumor representative, I would say, because there are stronger areas, but I also found areas that seem to me weaker, like this one, for instance.
Okay, so given that this is a very difficult slide, and I might not have given a diagnosis, so this is polyposis test. How do we approach this? If this was a diagnostic case on your desk, what would you do? I mean,
I always wonder if when you have such a borderline case, these are cases, excision specimens, do you repeat the test on a different block? Or, does it matter if it's
to hope
74?
So, we discussed this when we were doing the workshop, and I think your approach could be, I'll go and look at a different biopsy. Yeah. But if you look at another block from the same procedure, then you kind of need to average your observation across the 2 blocks or 3 blocks, etc. So you could say, well, let's see if I have another biopsy, which will give me a much clearer understanding of what goes on, because we said that in case of multiple biopsies, if one is positive, then it is eligible for treatment.
But I guess if you test another large block, then you have a more representative, even if you need to average it out.
You could, but if your problem is either tissue preservation, pre-analytics, or necrotic status of the tumor,
you may not find a good one.
Okay. So I think at the moment, I think this is a headache for me. Another bit of necrotic area is a headache. I think if this was a case, and we haven't looked at the other one, because to be honest with you, I remember now this case. This bit here, I was kind of thinking, I'm going to call this negative maybe. And then I looked at this one here, and then I made myself I gave myself more courage. This is what I wanted to discuss with you. You see these areas that look no staining, but actually this cell is positive, this cell is positive. So, I'm going to struggle. Maybe this cell is a negative cell, maybe this cell is a negative cell, but there are not as many negative cells as my eye catches it at the beginning. Okay, really difficult. I would say this is a case I would very gladly shift to my colleagues and say, I don't really know. Let's create a consensus diagnosis. So, any comments here? I don't know, but I think this is, I can't even remember whether I say positive or negative. It doesn't really matter. It is difficult. Okay, so is it wrong to say, we don't really know, let's call it positive?
Yeah, we can see that the participants, most of them thought positive in this case.
But not really. Look, it's 50-50.
No, because you've got borderline
positive. Yes, you're right.
So it's basically 80-something%.
You're right. Okay.
A lot of comments in the chat. If you were able to have a look at them, or
would
like me to read them out.
Here it is. Okay. I think it's about this case, Me, 10% of pathologists scored this positive. First score was clearly positive. Furthermore, okay. C positivo el 66% positivo is confusing. Not so sure what I understand what Moises means from this comment. 14% yes, yeah, I find very difficult. Guys, we discussed this case, is really difficult, and also understanding intensities as well. I agree.
Yes, I think
yes, so this comment, Trupti, is my understanding correct that the component, if the component of the tumor is considered unevaluable, should not be counted in the denominator? Absolutely. The whole thing is taken out of the equation. Absolutely. Okay, makes sense. A difficult case will give positive results. Okay, so yes, scoring surely this case should be assessed by few specialist centers. Well, yes. So one of our colleagues is making the comment that if this scoring really is important, of course it is important, then should this test be done only in few specialist centers because they see a lot of cases and they become more comfortable in diagnosis and better in the diagnosis. And obviously, yes, that's a short path to success. But if we do this for everything we need to do, and we start to say, I'm not so confident in diagnosing superficial spreading melanoma, maybe this should be reported by a specialist. I'm not so confident in reporting early invasive squamous cell carcinoma. And then I stop reporting everything. I think we need to make an effort.
And also, I think, sorry to interrupt you. I think it's this matter where you say of competence, but it's also, being reassuring is best if, these biomarkers are interpreted, or especially when we have for a certain tumor type, multiple biomarkers, if they're interpreted by the same pathologist, that would be ideal because you have much more control. You report an upper GI cancer and then someone says it's HER2 positive, but you also find, I don't know what, aberration, but maybe that was interpreted incorrectly because someone looked at the in situ component.
And you don't know that, yes. So
having an overview.
So what Adelina is saying is that actually you guys should be in control of the biomarker output from this tumor that you have diagnosed, because true, some of them are going to be difficult. I'm not sure, borderline, not sure if positive or negative, but you have a lot of other data point because this patient maybe has no PD-L1, positivity, and therefore no immunocheckpoint inhibition therapy. He has no HER2, so therefore no. He has whatever it is, mismatch repair is proficient, etc., etc. And then in that context, you may be able to say, although I'm not 100% sure that this is positive overall, I'm going to tell the clinician this is probably your best course of action. But if somebody examined this only for FOLR1, it doesn't know anything about anything else. So I think we are the owner of the case, is best placed at the end to do the best service for the patient.
And especially with what our colleague mentions with these dubious areas, when you perform multiple biomarkers, you can see that, this area is actually not staining properly for anything. So you definitely need to take it out from the assessment.
So Oliver brought up the fact that on top of all this, there is the fact that this test costs a hell of a lot of money. So it's really, really, probably we will deliver it losing money. So the whole thing is a bit shaky. Okay, true. We discussed that perhaps there are alternative way of doing the staining. It doesn't cost the earth. But and I understand the economical consideration. Perhaps the diagnostic companies that provide these tests may want to reflect on this and make these tests more affordable. But I understand, but I think true, maybe we should download it and give the problem to somebody else. That could be an approach. I don't know. Cool. Let's go to how are we doing for time? A bit pressed, but I think now the cases are easy. Clearly negative. Do we need to review this? I mean, everybody agrees. Well, I think a few people, I think, pressed the wrong button. What do you think? I think a few people pressed the wrong button, no? Okay. Do we need to look at it? I don't think so. We need to look at it? Yes. Anna says we need to look at this.
Just for ourselves to, that's 22.
22. Then it is, it's negative. What do you need to look at? Do you want me to open
Let's look at the immune only. Okay. I'm not very confident I will see moderate staining without opening the slide.
Okay, so there is a little bit of this little.
You wouldn't believe this at all.
I think this is the border.
The quality of staining looks, it's almost like it's not
quality
even...
of the scanning.
Well, that's another.
Yeah. Yeah, you're right. Maybe there is, or maybe it's just a cytoplasmic blob or something like that. Yeah, you're right. This is not, I don't like this, Okay. But even if this was real, I think clearly it's not a lot. Actually, there is a bit of tinge here. There is a bit of lumen.
But it looks mostly weak. And I don't know, it almost looks like it stains the apical portion of the cytoplasmic places, like
rather than create a nice border, you mean? Yes.
Here
it's fuzzy, you mean?
Sitting on top of the nuclei. I'm not
so
sure.
That's not a positive cell.
I don't think so. I find it hard to.
I know that Anne is online. If she disagrees, she can tell me. She has a problem. That's the best place to be. We can say what we like. I think Anne agrees with us that there is no staining. Okay, I think these, apart from very few areas or very questionable, members saying there is nothing here. Okay. Any comments? No. Where am I? Yep. And then slide 5, clearly negative. A few people thought not evaluable. A few people thought clearly positive.
Or borderline negative. About the fourth.
Yeah, a fifth, a fourth. Okay, that's case 25.
Let's see how much staining there is. 25.
Do I look at this or this? Why do we need to open slides like this? This should be on the tray. We don't even put on the microscope, no?
So you don't want to open it.
You see, the diagnostic companies and the pharmaceutical companies should come up with tests that you can report without a microscope. This would be the ideal situation. Okay, so
this is normal within the
tissue.
With the tumor. So you have fallopian tube.
And that's the.
So make sure you don't score that.
Okay. I'll open the HN. I can't see very well on the mist.
I think it would be easier.
Okay, so this was fallopian tube. This one.
Still fallopian
tube. Yeah, this is what we need to score. Yeah.
Is that the only tumor area? I thought there were. Maybe I'm mistaken that there were 2 areas.
Can't see anymore.
No, that's the only area.
Just here. Yeah.
Yes.
Okay, so now we know. And so it's here?
Just that. So they should be easier to score with tumor in one place.
Okay. I think, and it's not such a big area. You can really scan all of it. Do a cytology job. Oops, sorry, too much high power.
Okay, so how much do you think it is? Percentage?
Well,
15, 20, 15?
Not more than 50. I mean,
15.
well below 50%.
Definitely.
So yeah. I think I only have these things.
I thought 15.
Yes.
But maybe it's more, maybe
25. 20-25% so far. There are no classes that don't stain whatsoever. There are still a little.
I guess there are a few, but because you also have weak staining intensity, I think. So some of the smaller.
Nothing here. So there are areas with absent staining. Okay, I think this is an easy case. I think we were quibbling whether it is just below threshold. I think it's way below threshold, in my opinion. I mean, obviously, if you also take into consideration this, then you kind of raise the bar. But I think, as Adelina said, the tumor is only here. Okay, then we go to last case. Last case, clearly negative for the panel, clearly negative or borderline negative. There's always one or two people, well, maybe more than one or two people that think is positive or borderline positive. Quite a lot of borderline positive, no?
I have to say that with these biomarkers that have such a high threshold, like Claudine and FOLR1, when I have a lower threshold of also showing to someone else, because I'm not used to, the first impulse is when you see so much staining, then is to call it positive, perhaps.
Okay, let's see the slide. I forgot the case number.
It's 29.
29, this one here. And we have time to look at these.
We have a lot of tumor.
Lots of tumor. Masses of tumor. Potentially not very inflamed.
Not as inflamed.
Bit of hemorrhage in between. Okay. Most areas are potentially okay to score. Well, but I mean, this is what, time 5? No. This is time 5. So at time 5, I would say 50% in this area.
Possibly, yeah, because there's also some
intermediate. But now less, now fewer.
Perhaps, yeah. Now even, yeah.
Bit of, I don't know what now.
I think that is necrosis.
Yeah, there was a necrotic area. This is even lower. Yeah. So remember that at these circles, probably all the cells are going to be positive. We can have a look.
We can go at 10 or something to kind of separate
10. Yes.
The
10 would be here. Yeah, there is a lot of cells a lot of areas where I don't really see membrane staining.
Yeah, so that's the thing, the fact that you see sometimes your brain plays tricks on you, because you see you kind of extrapolate to the other cells just because you see color, but you need to be very kind of objective with your assessment.
So you know that there were a small proportion of people that thought this was a positive result. I think this is unlikely to be a positive tumor, no? I think about 15% of participants was positive, unless there is an area that is much richer, but I don't think there is. Let's have a look here. Oh, this is a bit better.
But we need to see how many tumor cells.
It's a bit better in terms of number of intensity of staining, but there are still negative area of overtly kind of significantly low numbers of staining cells. Look at
here is almost a lot of it is weak staining.
Yeah. Okay. So I mean, again, my suggestion, if you guys thought this could have been positive, my suggestion would be to do what Bharat said to me, just pick up. I think we used to do this review, 20 random high power field review for PD-L1, and to say, okay, I think this is PD-L1 positive. I screen 20 high power field. Why high power field? Because there are fewer things to look at. So it's more limited. And if out of 20 high power field, I get very few areas where I say, oh, that's a positive area, then I go back and think about it seriously, because the randomness of the choice means that I should find significant large number of high power screen with positive staining. So something like this is not going to be 75%, no way, no? And you can do this randomly, so this is your thing, so you just put another area. What do you think of this? Okay, again, very poor. Let me go on slightly lower power because it's a bit fuzzy. Okay.
Yeah, and it's
not 75%. Let's pick up another area.
I would say even below 50, just below 50.
This is not positive. Let's pick up another area. So you see, you can do this random review. This is a little bit better.
This is a bit better, but
maybe not enough. Or okay, but again, you know, we've done 4 areas, 3 clearly negative, 1 maybe. Okay. Yeah. But if I wanted to hold this case positive, I should have found 3 positive and 1 maybe not, the other way around, you know.
That's a very
and so if you do this enough, you know, if you do these 5, if you do these 10 high power fields or 15 high powers or 20 high power fields, you gain confidence. Yes, my diagnosis is correct. Or no, actually, I can't find evidence for it.
Good trick.
Yeah. Okay. So let's go back to here and let's see if there are chats, chit chats. Last. How many tuber-ovarian epithelial cancer does a typical DGS department will say with say 25,000 specimens and 6 pathology see in a year? I don't know. Yes, we are happy to outsource. So this is Richard. Richard says, really, we see very little. We probably will outsource it. Yes. Okay. Absolutely. But maybe FOLR1 or another biomarker, it doesn't matter, will become relevant for other tumor sites, you know, and then other tumor sites. So maybe actually you will not see 100 or 80 samples a year. The workload may be different. Okay, I do understand. In any case, I'm really happy you guys participate, because even if you are not going to score it, at least you know what it's all about. So you will be able to interpret reports that are sent to you. Then Moises says case 2 and 3 were extremely controversial, but the explanation was very clear. Thank you. I thought not, but anyway, in agreement, fantastic. Okay, we have more slides. We have more slides. Just a moment. More slides. So this is a cross audit of how many people had reporting experience of FOLR1, and you can see, you know, frequent pathologists reporting frequently, it's green, less than 20%. So cool. Okay, I'm here. No, I'm probably here at the moment. Okay. Fantastic. So thank you very much. There are some comments here. How should we write the final report? I think we kind of went through it in the webinar.
Yeah.
I think I would say you need to say what antibody, what test you use, what scoring algorithm you use, just to frame it. What is the threshold for positivity, and then what is the outcome of your assessment? Is this positive or negative for this indication? And maybe I would give a little comment to say there is abundant positivity. I have no problem in reporting it, or this is a difficult case, and perhaps I discussed this with another colleague, because it's really difficult, something like this, to kind of frame it. Okay, that's very good. I would say we stop sharing. We have 5 minutes for anybody that wants to make additional comments. Today we didn't have Emilia speaking to us. Why? Does she not like us?
Emilia is busy with other
issues
right now.
Okay.
I was thinking also, because for this one is the first time we use so many excision specimens, but probably do you think there will be a shift in, you know,
in some biopsies? I don't think so.
We will have a lot of cytology, which is maybe will not be ideal.
Because at the moment we cannot really, you know, the test is not really validated for cytology. Yes. So yes, there'll be some challenges ahead. in this space.
I think it's much more difficult to look at the whole excision specimen, although it might give you more information, to be fair.
Okay, guys. So just a few housekeeping things to do. If you are interested in kappa and lambda light chains with high sensitivity, there is a webinar on 26th of November, and then we open a circulation. Although many of you say this is a lympho-reticulopathologist problem, it's not really, because I think as general pathologists, we see a lot of things where we don't want to miss lymphoma. We're not that sure.
We've got a lot of B cells, plasma cells, and we wonder, are these clonal?
No, so plasma cells is okay because the existing tools which are in situ hybridization for kappa and lambda, this is low sensitivity, will stain your plasma cell. You show plasma cells is monotypic or polytypic. But if you have small lymphocytes, the normal in situ hybridization doesn't really hit them. But now this high sensitivity will show you have a marginal zone lymphoma or potential marginal zone lymphoma is polytypic. Okay, I'm not calling this lymphoma.
Plus, this is duo staining, so
in the same
I would prefer it in any case.
So quite nice. So please log in for the next round, and thank you very much for supporting us.